my name is Hans Aurora, and today I'm going to demonstrate how to put in a chest tube. So here we have our patient. We imagine we're in a trauma situation, so it's important to let everybody know that we're using sharps. Hey, we're using sharps! Now with our patient, we have to find our landmarks in order to figure out where exactly we need to put our chest tube. So we can find the sternal angle and palpate down till we find our fourth intercostal space, and then palpate over, and we find our mid-axillary line, and we want to go just anterior to it so we don't hit the muscle. Now this patient actually has had a chest tube previously placed in that area, so we're going to move one rib space lower for this particular demonstration. Now that we've found our area, we can go ahead and mark it just using a hemostat or something of the like, just to make a small mark so we know exactly where we need to go. At that point, we can go ahead and prep the patient sterilely if we have the time, and then drape them appropriately, making sure we have our own personal protective equipment. And then we would want to take some lidocaine in order to anesthetize the area, making a wheal under the skin, and it's important to let the patient know that this is going to be very uncomfortable and even a little bit painful. Now, in addition to the skin, it's important to anesthetize the subcutaneous tissues and also the periosteum as well, and getting close to the pleura where we're going to be inserting the chest tube. While we're waiting for the anesthetic to work, we can move over and look at our equipment. So we have our Kelly's or Curve 6, and we have a large bore, in this case 36 French chest tube, which is important in a trauma situation, which we can prepare with the tips of our clamp close to but not passing point on the chest tube itself. We can use our hemostat to clamp off the other end so that when we do insert the chest tube, nothing is coming out immediately. Once that is prepared, we have a scalpel, some suture, and then more clamps in addition to a needle driver. So, going back to our patient, now that they're anesthetized, we make sure we have our area. And using our scalpel, in a trauma situation, we might make a very large incision. In this case, instead of going 5 centimeters, we might go 3 or 4. Right over the bone. We don't want to go inferior to it, because if we go inferior, we run the risk of hitting the neurovascular bundle. So once we've found our area, we take our clamp, we point it just above the bone, my assistant holding the mannequin, using a two-handed technique to make sure that we don't end up poking all the way past the pleura into the lung. We're going to apply force until we pop through the pleura. Now we don't want to pull the clamp out right away, but instead we want to open it in order to spread out that space, using our finger as well so that we don't lose our opening. Alternately, we can use the clamp and our finger, or just use our hand in order to stretch that space, but it's important not to lose it. Now, we can take our chest tube, which was previously prepared, and insert it over the rib into the pleural space, going down, and once we're inside, we can also go superiorly. When we can't insert the clamp anymore, we can release it, pull out now that we have the chest tube in place, and we can advance our chest tube. Once our chest tube is advanced adequately, then we can secure our chest tube with suture. We have a suture here with our needle driver. We can do a U-stitch in order to secure our chest tube. We use a large needle. In this case, we may need to take it in 2. That's my assistant to hold the chest tube out of the field. And then I can cut off the needle. Needle back. And then I want to make sure I just put one throw, just to put the needle down. Just to put the suture down, and then I can wrap it around the chest tube. I'm going to go multiple times so I have some extra suture. Make sure I don't end up with a sandal technique as I push the suture down every few times that I go around the chest tube. When I feel like it's secured further down enough, then I can go ahead and tie down my chest tube. Doing a few throws to make sure that I've adequately secured it. And once that's secured, then I can go ahead and attach the other end of my chest tube as need be and remove my clamp.